This is a case of azotemia associated with tetracycline use. We have a 77-year-old female with a past medical history of CKD stage 3B, recurrent UTIs, hypertension, and bipolar disorder, who presented with intractable nausea and vomiting for 4 days, decreased appetite. Of note, she was recently hospitalized for a complicated UTI and discharged home to complete a 7-day course of tetracycline. This particular antibiotic was chosen based on urine culture sensitivities. Her BUN creatinine ratio was elevated to 42, raising concern for an upper GI bleed. However, her hemoglobin remained stable throughout admission without any signs or symptoms of bleeding. Her renal function approached her normal baseline after receiving supportive care with intermittent maintenance fluids with lactated ringers. Some mechanisms of drug-induced nephrotoxicity to consider include changes to glomerular hemodynamics, tubular cell toxicity, inflammation, and crystal nephropathy, to name a few. The treatment of AKI mainly involves, first and foremost, treating the underlying cause, or in this case, removing the offending agent, as well as fluid resuscitation. Hemodialysis is indicated in anuria, refractory hyperkalemia, volume overload, and uremia. As acute cystitis is extremely common in both inpatient and outpatient settings, with growing rates of antibiotic resistance, we are now faced with new challenges regarding antibiotic selection, and it is important to have an increased awareness of rare side effects of these drugs that are less commonly used. First and foremost, it is important to remove the offending agent in acute kidney injuries and providing fluid resuscitation.